Sepsis, blood clots, pulmonary embolism, fat emboli. If you're worried about these, you're gonna wanna watch this video. I'm gonna go into all the detail, complications of BBL. Watch this video. There's something else that comes from grafting fat, and that's something called a fat embolism. And that is something that gets a lot of publicity and is what gives the dramatic headlines of, death with BBL, for example. So it can be fatal. I've never had a patient have a fat emboli. I follow all of the techniques developed through the American Society of Plastic Surgeons related to safely performing a BBL, which means a lot of things, but primarily we're going to be injecting the fat underneath the skin, in the fat level underneath the skin, but above the muscle. And it used to be in the past, when the whole technique of a BBL was developed, we would inject below the muscle, in the muscle, and above the muscle as well. And we really liked injecting in the muscle because the muscle has a really good blood supply. And we found that our fat injected in that area did very well. But we then later found out that injecting below the muscle or in the muscle was associated with a much higher rate of fat emboli. So let's just take a step back. What is a fat emboli? Well, an emboli, it just means something that's goes into a vein and returns up to the heart and gets pumped out to the lungs. Now you can imagine that can either be blood, it can either be fat, it can be a foreign object, and any of those things can go, and once they gets pumped out to the lungs, they're going to block the blood flow to the lung. Obviously, if you're blocking the blood flow to the lung, you're not going to get oxygen. If you're not going to get oxygen, it can be fatal. So that's what a fat embolism is. It's when a little globlet of fat, usually a bigger one, will get into one of the large veins, and that gets transported back to the heart and pumped to the lungs. And so that can be a fatal complication. It's something that's much less now that we don't inject below the muscle or in the muscle, and we just inject beneath the skin into the fat. And sometimes patients will ask me, like, well, how do you know where you are where you're injecting? And it's kind of difficult to explain. I know people talk about ultrasound and things. I'm not really sure that that's practical to be able to try and follow your cannula the whole time, but it's really just a feel as to where you are. And as a surgeon, we have years of experience in assessing the different depths and tissue planes, and you can kind of feel where you are, and you would know if you're below the muscle or in the muscle. And there's little sort of signs that will tell you that. So that's kind of the most dreaded complication, and but thankfully it's not very common. And when you first start reading about any procedure, and I know myself when I went through medical school, you start looking at things. Even if you look at just regular treatments like, taking an antibiotic, well, you can have, you could potentially die from an antibiotic, but it's extremely rare. And when you're a student or you're a patient or family member, you can kind of hear all these complications, but you don't know, is infection like really high, or is a fat emboli really high? And no, those things are much lower. And things that are more innocuous or benign or easily treated are things like seroma, where they happen more frequently than something like an infection or something like a fat emboli happens. So it's important to kind of understand these things. A couple other things that I want to bring up. One of them is this term sepsis, because I hear this coming up more and more frequently. And I want to sort of address that. And I want to talk about a blood transfusion after a BBL. So these things usually kind of go hand to hand. So here's what the typical scenario is. Patients will have a BBL, they'll have liposuction. When you have liposuction, there is bleeding. Obviously, when we're doing any type of surgery, there's bleeding. Now, we use medications that cause the blood vessels to constrict to try and limit the bleeding. It's why we place you in a faja after surgery to keep compression, to limit bleeding. But if you look at all of the factors that go into producing bleeding, there are just different levels. Patients will start off with different hemoglobin levels. Patients will have different types of fat. Some fat is more fibrous and bleeds more. Sometimes patients will have a second round liposuction. Well, if you have second round liposuction, you're going to bleed more than you did the first time because there's scar tissue, and that scar tissue bleeds. I operate with my OG lipo high in the back. The upper back tends to bleed a little bit more than the lower back. So there's a lot of factors that go into patients bleeding. We use the cell saver. I use cell saver for every patient to try and scavenge all of that blood to help limit the blood loss. But even still, despite all of these precautions that we take, patients occasionally will still need a blood transfusion after a BBL. It's not common, but it certainly does happen, and it's happened with my patients. Patients will be dizzy, lightheaded, they'll have a fast heart rate, they'll be pale, they won't feel well. So that patient will go to the hospital to get a blood transfusion. And here's where some of the confusion comes in with the term sepsis. So I just want to address this. Sepsis, when I trained and in medical school and residency, is a very, very, very serious problem. And there's a real mortality rate associated with sepsis. And sepsis, in and of itself, is a cause of death in the United States in intensive care units. But sepsis is not something that you experience after BBL the next day. Sepsis is something where you have multiple organ failures, your heart, your liver, your kidneys, your lungs, because there's an overwhelming infection in your body. Now, I have had patients get diagnosed with sepsis after BBL the next day because they have needed a blood transfusion and they have gone to the hospital because their hemoglobin is low and they need a blood transfusion. They will have their blood drawn to see what their blood level is, and they'll find that their white count, their white blood cell, remember that, those are the cells that fight infection, are very high. And that is normal after having a BBL. That's your body's inflammatory response. That's normal part of healing. Your body will send out the white blood cells and your white blood cell count will be high. Sometimes, I'm not sure why, but they get diagnosed then as being septic. And I will be talking with patients, and seeing patients, and they'll say, "Oh my God, I've got sepsis," you know, and it's just not true. And so you have to be really careful of how that word sepsis is used, because if someone is septic, it really means they're in the intensive care unit with a breathing tube, they're having medications to support their blood pressure, and their organs are failing. After having a high white blood cell count after a BBL is not sepsis. And so I just want to kind of clear that up, because I do get some people really concerned, and I think it's unfortunate that patients will go in the hospital to get a blood transfusion, they'll be told that they're septic, and then they get their blood transfusion, they go home the next day. And it's like, well, how can you be septic? And they're sending you home the next day. So that's a really important term to understand, and to understand when it, how it's used correctly. Another complication to talk about is something called lipo burns. Now, I've made other videos on this to explain that a lipo burn is really not a lipo burn. It's not actually a burn. A burn is something that's with heat, with thermal energy. You can get burned with smart lipo or lasers or ultrasound or some of these other techniques that use heat. That can actually produce a true burn. I don't use any of those techniques that provide heat because they create more scarring and fibrosis. But you can still get a burn from traditional liposuction, which is the liposuction I perform. But it's not really a burn. It's not heat. It's just a lack of blood supply to the skin from the liposuction. And that can cause an area of the skin to die underneath or over top of that area underneath where the blood supply has been disrupted. It's not common, but I certainly have had patients with lipo burns, and I know in the future I will as well. Despite trying to perform as careful liposuction as I can, there's still areas of the body with lower blood supply, particularly in the side flank area, where that naturally has lower blood supply, and those areas are at higher risk. And it's just kind of gets down to the root core of the complication, where you can perform liposuction in 300 patients and not have a burn, and then you perform liposuction in the 301st patients and you have a burn because their blood supply is different, or there's some other factors that are different. So despite doing the same technique, you can have a complication. Doesn't mean something wrong was done, but it means that that area is lacking blood supply. So that area has to be recognized, and then we treat it. It can produce a scar, and that's something that's obviously the most concerning thing that we have, and it just depends on the depth of that injury. So for patients that have a very superficial, meaning just the upper part of the skin is lacking blood supply, they typically really don't have much of a scar. And that's the most common type of lipo burn. There are patients who will have a more deep injury, and that whole skin will not survive, and those patients will have a scar afterwards. And so we work with those patients to try and get the very best scarring that we possibly can, and a lot of that is with massage and silicone. But that's a lipo burn. It's not very common, but it certainly does exist out there, and it's important for us to recognize it and treat it when we see it. Okay, let's talk about blood clots. So a blood clot, or also known, what we call it, is a deep vein thrombosis. Thrombosis just means clot, and that means a blood clot in the deep veins. It's not very common with a BBL. It's more common with a tummy tuck. It's more common with patients that have hip or knee replacement surgery, for example. So in terms of a BBL, a blood clot can happen where the blood just slows down, the circulation slows down because your blood pressure goes lower when you have an anesthetic, and that blood can pool in your leg. It can kind of collect there and form a clot. And then we will do an ultrasound, which is just a little test where they run this probe over top of your veins, and they can look and they can see if you have a blood clot. The concern with having a blood clot is that blood clot can flip off and go to your lungs and cause what's called a pulmonary embolism. Pulmonary embolism, similar to a fat embolism, where that blood clot will block the blood flow in your lungs, and that will limit the amount of blood circulating through your lungs, and that will limit the amount of oxygen that can get into your blood. Obviously, with not enough oxygen, you're going to have a problem. There's various different sizes of pulmonary embolism. Some are small, some we don't even detect. We only can see them when they've done studies with ultrasound probes down in the esophagus and things during heart surgery. But some of them are not detected. Other ones can be potentially fatal if they're bigger. If they're bigger, they will block off all the blood supply to the lungs. Fortunately, this is a very, very low risk after having a BBL. It's a little bit higher with a tummy tuck. So I use a blood thinner, it's called Lovenox, in patients that are having a tummy tuck, because we know that that's a little bit higher risk of having a blood clot. The best treatment for a blood clot, to prevent a blood clot, is to stay well hydrated during the surgery, which we do, give you a lot of fluids. That's why you swell. That's why you have to pee a lot on day 3. But the best thing is what we call early ambulation, which means early walking. That's why outpatient surgery is a great way to prevent a blood clot, because you're going to have to walk to your car, you're going to have to walk to your house. It's different than if you're in the hospital, where you get wheeled everywhere. From the recovery room, you get wheeled up to your hospital bed. You may have a catheter in, you may have a pain pump, and there's really not a lot of need to get up, because you don't have to get up to take a pee with your catheter. But when you have surgery as an outpatient, which is what we do in our office, you have to go home and you have to walk because you don't have a catheter in your bladder. You're going to have to get up to pee. We don't like patients using commodes or something that they just get up and take one step and use the bathroom. I know it's uncomfortable to walk after surgery, but you have to get up and walk after surgery. So that's more important to prevent a blood clot, just getting up and walking, than taking a blood thinner or any other way. We also use some compression devices, kind of like calf massagers in the operating room, which have been shown to decrease the risk. And we also use embolic stockings, which are those compression stockings as well. So we take all the precautions we can, but the simple and most effective way to prevent a blood clot is to walk early. You don't have to walk far. You don't have to be walking out in your neighborhood after surgery, but you have to walk frequently. So every hour, I tell the patient's caregivers, you need to practice tough love. You need to get the patient up every hour. No one's going to want to do that. But that's the best way to prevent a blood clot, is by early ambulation. Getting up and moving, just simply from your bed to the bathroom, is sufficient. If you can take a little lap around the bedroom, that's even better. But early walking, that's the best way to prevent a blood clot. Hey, thank you very much for watching. I always appreciate, my goal is always to educate. I want you to be informed so that we can have a good conversation when we have a consultation. And complications is something that is always discussed. And so I think having some basis, some background, some understanding will really help sort of both of us communicate when we're talking about a BBL. Thanks very much. Have a great night.